Hello, professional nurses. This is Mrs. Ignacio with your respiratory system overview and respiratory system alterations. So let's go ahead and begin. During this session, we're going to talk about the respiratory assessment, percussion of lung sounds, adventitious lung sounds, diagnostic tests, asthma, status asthmaticus, as well as COPD, carbon dioxide toxicity, pneumonia, tuberculosis, laryngeal cancer, lung cancer. Let's go ahead and get started by talking about the respiratory assessment itself. So with any assessment or any focused assessment, we always want to introduce ourselves, perform hand hygiene, identify the patient, assess for allergies. We'll also assess for our level of consciousness in the patient, their orientation, their mood and affect. We will also assess their pain on a pain scale from 0 to 10, 10 being the worst pain. We also want to assess if the patient is using any mobility aids. Do they have any dressings, ostomies, IVs? Do they have any specialized mattresses, right? Anything that the patient is using to help them complete their ADLs. Of course, we will take our vital signs. And we will also pay particular attention for this respiratory assessment to the patient's rate, rhythm of breathing. Is the breathing labored or is it unlabored? Are they struggling to breathe? And we will also note the use of accessory muscles. We will assess the patient's fingers and toes for clubbing. And we will also ask the patient if they have any history of lung trauma, exposure to environmental pollutants, anything that could affect their respirations. And that also includes smoking and vaping. We will inspect the thorax for symmetry and configuration. So we're looking to see maybe if that patient has a barrel-shaped chest, which is common in your asthmatics and your COPD patients. We will also note the patient's posture. The posture should be upright. Okay, and let me just check something here. Okay, just wanted to make sure that I was still sharing the right screen. All right, so we also will again look for their posture. The posture should be upright. If the patient has a hunchback, that is known as kyphosis, and that could alter their respiratory status. And it could make it more difficult for that patient to breathe, as well as it could be a fall risk for that patient because their center of gravity is changed. We will palpate the anterior and posterior chest wall surfaces, looking out for any masses, any tenderness. And then we will percuss. We will place the non-dominant hand over the area of percussion and then take the middle finger of our dominant hand and then tap on the first knuckle of the middle finger of our non-dominant hand. So again, that dominant hand, that middle finger, will be tapping on the non-dominant hand's first knuckle of the middle finger. And when we percuss, we want to get resonance, the sound of resonance in all fields. We want to make sure that we auscultate the anterior and posterior lung fields. And we're going to look out for adventitious sounds, which we will talk about in just a minute. And we will also talk about, assess for chest expansion. So we want to make sure that expansion is bilateral. So we will place the hands on the patient's back and ask them to breathe deeply, and we should see our thumbs actually moving apart. If we have both hands on the patient's back, we should see our thumbs moving apart in a symmetrical way as the rib cage expands. Okay, so when we think about respiratory, we want to understand the percussion sounds of the lungs. So flat percussion is what's going to be high pitched, and this is going to be the sound that's heard over dense tissue, for example, over the liver. There's also dullness, and this is a medium pitch, and this is a combination of solid and fluid-filled areas. right? Maybe a patient that may have pneumonia may have sounds of dullness upon percussion. Now, resonance is the desired sound that you want to hear. And so these sounds usually have a low pitch. Okay, so resonance is the desired sound over normal lungs. Hyperresonance, this is also low pitch sounds, but they're going to be lower than resonance. And so this patient is having hyperinflated lungs. And this is very common in your emphysema patients, okay, your COPD emphysema patients. Now, timpani sounds are like drum sounds, and so a gas-filled area can cause tympanic breath sounds, and also a pneumothorax can cause these tympanic sounds. So the sound that we want to hear is going to be resonance. Let's talk about adventitious breath sounds. If you want to hear what these sound like, please check out easyauscultation.com. They do have a great website for listening for lungs and cardiac sounds. The first adventitious sound is going to be crackles. Sometimes crackles can be called rails, and so crackles can be fine, medium, or coarse. And so when we have these crackles, I'm thinking that this patient may have wet lung sounds at lower parts of their lungs or at the bases of the lungs. This is also associated with your patient that may have fluid volume overload, right? These wet lung sounds. Now, wheezes, this is described as a musical sound, right? And so this is a high-pitched musical sound, and this sound can be heard upon inspiration and expiration. And the kind of patient that could have wheezes would be your asthma patient. And when you hear wheezing, it's usually bilateral. Now, if your wheezing is unilateral, that may be due to an obstruction, and that is also possibly stridor. When some foreign body, maybe a small child, swallows a marble or aspirates a marble, and it is actually stuck, you will hear that sound, right? And that is stridor. Okay, the next adventitious sound is rhonchi. And so if the patient has thick secretions, the air that flows over them, right, will cause rhonchi. So when the patient actually coughs, they can clear this sound. This is most commonly seen in your chronic bronchitis patient. Okay, the next sound will be friction rub. So when we talk about friction rub, it is caused by inflammation of the pleural space, and it sounds like sandpaper that's actually two pieces of sandpaper that are actually rubbing together. And so you will hear these friction rubs during inspiration and expiration. Okay, let's now take a look at diagnostic tests. Whenever we perform tests on our patient, we want to really remember that we will start with the least invasive and then work our way up. So we won't automatically start at a biopsy or a bronchoscopy. We're going to do other things before that. So diagnostic tests for respiratory disorders can include the non-invasive ones, which will be chest x-ray, and we must use a lead shield for adults of childbearing age. Pulse oximetry is another diagnostic non-invasive kind of test or procedure. Pulmonary function test, sputum culture, computed tomography or CT, tomography rather, or CT, magnetic resonance imaging, that's going to be your MRI, right? And so just some considerations for these tests, right? With the sputum culture, we want to collect that first thing in the morning. That's the best time to collect the sputum culture. And if antibiotics is going to be involved for the patient's care, we will get the cultures before we start administering antibiotics. For CT tomography, we want to make sure that we assess for allergies for shellfish and iodine. And for MRI, no metal should be in the patient's body, right? So if a patient has a pacemaker or metal screws or bars, then an MRI is contraindicated. For both your CT and MRI patients, we have to make sure that we assess them if they're able to lie still for 45 to 60 minutes, because that's how long the procedure will take, and also if they have any issues with loud noises. Okay, so let's now talk about the invasive procedures for respiratory disorders. Arterial blood gas, okay, arterial blood gas, also known as ABGs. And so this is going to be a puncture, an arterial puncture, or maybe if the patient has an arterial line, we will take that blood. Now, this arterial blood gas allows the most accurate method of assessing respiratory function. We will perform the Allen test if the patient does not have an arterial line. And with the Allen test, we're going to actually depress or occlude the radial artery and see if the patient's hand actually will change colors. And you should see the patient's hand as you're depressing that radial artery going from a pink or, color according to their ethnicity to a pale white color. And then when you release that artery, the radial artery, the color should go back to their hand. That means that is a good patent artery that you can draw blood from. Now, the sample is drawn into a heparinized syringe. We must keep it on ice and transport it immediately to the laboratory. We will document the amount and the method of oxygen delivered to the patient so we can have accurate results. And we will also apply direct pressure to the puncture site at least 5 minutes longer for the patient who is at risk for bleeding. So because the arteries are under high pressure, we're going to have to make sure that we apply pressure so this artery will stop bleeding. We don't want the patient to start hemorrhaging from that site that we drew the ABGs from. We will also monitor this patient's site, this arterial blood gas draw site, for hematoma, which is a blood bruise. The next diagnostic test is going to be bronchoscopy. In a bronchoscopy, the larynx is visualized as well as the trachea, the bronchi, and the provider may also obtain a tissue biopsy at this time. They can also remove any foreign bodies. Say that child that, aspirated that small marble. If they find it, they can remove it at that time. So things to consider for the bronchoscopy is that we must have an informed consent. It must be scanned into the patient's record. Maintain NPO 8 to 12 hours prior to the procedure. Provide local anesthetic throat spray. Position the patient upright, and we will administer medications as prescribed. Atropine can be administered to reduce oral secretions, and also sedatives can be given, or anti-anxiety medications may be given as well. We will label the specimens during this bronchoscopy, and post-procedure, we want to assess for gag reflex. Do not administer anything by mouth unless there is a gag reflex. We will look out for signs and symptoms of bleeding. So that's why the vital signs are so important to assess. We will also assess the respiratory status and their level of consciousness. All right, the next diagnostic test for respiratory system alterations will be the MAN2 test. Positive test indicates that the patient has been exposed to tuberculosis. This does not mean that they have an active case of tuberculosis. It just means that they have been exposed. Now, the diagnosis of tuberculosis must be confirmed with sputum cultures for the presence of acid-fast bacillus. So the diagnosis of tuberculosis must be confirmed with a sputum culture for the presence of acid-fast bacillus. Now, for the MAN2 test, we're going to administer a very small amount. This is 0.1 ml of purified protein derivative. And this is going to be via intradermal injection. on the inner surface of the forearm, and the needle will be inserted bevel up. The angle of insertion for this needle is between 5 to 15 degrees, and we will just make a little wheal or little bleb on the surface of the skin. Okay, that you will be just under the surface of the skin. With the Mantoux test, we will assess for a reaction 48 to 72 hours following the injection. We're going to be looking out for an induration or hardening of that area where the injection site is. So 5 millimeter induration, that is going to be considered a positive test if your patient is immunocompromised. Examples of immunocompromised patients will be your HIV patients, patients that are taking immunosuppressive medications, like maybe an organ recipient, right? So those patients, if they have an induration of 5 millimeters, that is going to be a positive test. A patient that is not immunocompromised, a positive test would actually be 10 millimeters or greater. Okay, so that is your Mantoux test. Let's now talk about the TB Gold test or the quantiferon test. Maybe some of you got this done for your Castle Branch requirements, right? So the purpose of this test is to identify the presence of Mycobacterium tuberculosis infection. And so what they're doing is measuring the immune response to the TB bacteria in the whole blood. Okay, so that is your quantiferon. That is the gold standard. Okay, so the next invasive procedure that falls under diagnostic tests will be thoracentesis. Thoracentesis. So this is a surgical perforation of the pleural space to obtain a specimen. Okay, so we're removing fluid or air with the thoracentesis, and they may even instill medication during this thoracentesis. So what are the things that we have to consider for a patient having a thoracentesis? Well, obtain informed consent, educate the patient to remain still. They may have a feeling of pressure, positioning, and the position should be in an upright position. We will monitor respiratory status and vital signs, label the specimens, document the client's response, the amount, color, and viscosity of the fluid, right? And just remember that a maximum fluid that can be removed at any one time during this thoracentesis is 1 liter. There will be a chest tube placement at the bedside, and the chest x-ray should be obtained before and after the procedure. So when we talk about chest tubes, just remember one of the questions that you can see, if there is a continuous bubbling in the water-sealed chamber of a patient's chest tube, then that could indicate an air leak. And the chest tube is also very similar to the Foley catheter, right? In the sense that it should be placed below the level of the chest, just like the Foley catheter collection bag should be placed below the level of the waist. All right, that concludes the discussion of the diagnostic tests. Let's go into our first disorder of the respiratory system. And I just want to make sure that you remember, though, that the respiratory system includes our upper airways, our lungs, our lower airways, and alveolar sacs. And those alveolar sacs are at the base of the lungs. And that the lungs themselves, they aid for the body's oxygenation and tissue perfusion. So let's talk about asthma now. So asthma is a chronic inflammatory disorder of the airways, resulting in intermittent and reversible airflow obstruction of the bronchioles. So remember, we have the trachea, the bronchi, that are 2 branches coming off of the trachea. There are smaller branches coming off of the bronchi called bronchioles. The bronchioles end in terminal bronchioles, and at the end of those are going to be your alveolar sacs that look like clusters of grapes. And in your asthma patient, as you can see, there's going to be narrowing of this airway, and that is what's creating the problem. All right, now when we think about asthma, the contributing factors, well, there could be an antigen antibody reaction that could be triggered by food, medications, inhaled substances. It could be pet dander, right? Strong perfumes, smoke, pollution. There's also factors that could be maybe there's some pathophysiological abnormalities within the patient's respiratory tract. Now, for older clients, we have to keep in mind that beta receptors are less responsive to agonists and they can trigger bronchospasms. What are the manifestations of our asthma patient? Well, they can have sudden severe dyspnea, difficulty breathing with the use of their accessory muscles. You may note nasal flaring. You may note retractions. The muscles in their neck will be more evident as they're struggling to breathe. They will have labored breathing. They'll be sitting up, leaning forward. They may have diaphoresis and anxiety, wheezing, gasping, coughing, cyanosis, which is a late sign of asthma, and the patient may also have a barrel chest. So the patient may also have a barrel chest. So diagnostic procedures for this patient with asthma can be your ABGs, sputum cultures, pulmonary function tests. What are the nursing interventions for the patient with asthma? Well, we will remain with the client during the attack. We will position the patient in high Fowlers, assess the lung sounds and pulse oximetry. We will administer oxygen therapy and maintain an IV access. The medications we could expect to see to give this patient during an acute exacerbation will be bronchodilators, right? And so these bronchodilators, short-acting inhaled bronchodilators. Albuterol is usually the medication of choice, and that is for rapid relief. We also can see the methylxanthines. Theophylline can be given, and theophylline is one of the medications that we have to carefully monitor for therapeutic level. So the normal range for theophylline is going to be 10 to 20 micrograms per milliliter. So for theophylline, again, the therapeutic range is 10 to 20 micrograms per milliliter. So when we think about theophylline, we have to make sure that we are looking out for toxicity, okay? So also the medications that may be given to this asthma patients are anti-inflammatory medications such as corticosteroids, and that is your fluticasone and your prednisone. Also, they may be given leukotriene antagonists, which is your montelukast or your Singulair. And then combination agents can also be given, and that's your ipratropium and albuterol combination, or your fluticasone and salmeterol. So please note that with inhaled agents, we will administer the bronchodilators before any anti-inflammatory medications. The reason why we do this is to use the bronchodilators to open up those narrowed airways so the anti-inflammatory medications can get deep into the airways where they need to work. Okay. Now, other therapeutic measures we can take for the patient that has asthma are going to be respiratory treatments, administering oxygen, and the patient teaching is going to be avoidance of allergens and triggers. So if we know, for example, that little Johnny is allergic to cats, please don't get little Johnny a cat as a pet. They probably need to get a goldfish, right? We also want to make sure the patient understands and is taught how to use their inhaler properly, and also that they will have peak flow meter monitoring. They should be doing that daily or periodically as determined by the primary healthcare provider. Let's talk about status asthmaticus. So, this is a life-threatening episode of airway obstruction that is often unresponsive to treatment. So, this is a very critical condition. ICU level care and support is required for this patient. The manifestations of status asthmaticus will be extreme wheezing, labored breathing, the use of the accessory muscles, distended neck veins, and there is a high risk for cardiovascular and or respiratory arrest. So the nursing interventions for status asthmaticus will place this patient in the high Fowler's position. We will prepare for emergency intubation. We will administer oxygen, epinephrine, and systemic steroids as prescribed. We will provide emotional support. Okay, so this is a very serious condition. Okay, and a lot of times the lungs are no longer responsive to these emergency medications. All right, let's now jump into COPD, your chronic obstructive pulmonary disease. So, this condition, COPD, encompasses both chronic bronchitis and pulmonary emphysema. So, let's talk about chronic bronchitis first. Okay, and it's important to remember that these respiratory conditions are irreversible. So your chronic bronchitis patient is the gentleman that you see on the left. Chronic bronchitis patient is also known as a blue bloater. So with a patient with chronic bronchitis, they're going to have inflammation and hypersecretion of mucus in the bronchi and bronchioles. And this is caused by a chronic exposure to irritants. So, what are the contributing factors for a patient with chronic bronchitis? Well, cigarette smoking is the main causative factor. Also, possible contributing factors may be exposure to air pollution and other environmental irritants. The manifestations for a patient with chronic bronchitis: productive cough, thick, tenacious sputum, hypoxemia, respiratory acidosis. Okay, so remember respiratory acidosis. They're not able to release that carbon dioxide. Diagnostic procedures for your COPD patient will be chest x-ray, pulmonary function test because air remains trapped in the lungs, pulse oximetry, which is often less than 90%, ABGs can also be done, right? Especially when we have our patient facing chronic respiratory acidosis. CT will also or can also be done. Okay, let's talk about now the manifestations and contributing factors for your emphysema patient. Now, emphysema is destruction of the alveoli, the narrowing of the bronchioles, and trapping of air, and this is resulting in a loss of lung elasticity. The diaphragm can also be flattened. And so the contributing factors for this condition of emphysema could be cigarette smoking, which is the main causative factor, passive smoke inhalation, advanced age, exposure to air pollution, or maybe the patient has an alpha antitrypsin deficiency, which this deficiency will cause the patient to have an inability to break down pollutants. Also, occupational dust and chemical exposure can contribute to emphysema. The manifestations of emphysema: well, dyspnea with productive cough, difficult exhalation, right? So they will use pursed lipped breathing. The patient may have wheezing or crackles, a barrel chest, shallow rapid respirations, respiratory acidosis with hypoxia, weight loss, clubbed fingernails, and fatigue. So now that we've looked at the manifestations of chronic bronchitis and emphysema, let's take a look at the nursing interventions. Well, using the nursing process, we want to assess the respiratory status, assess the cardiac status, looking for signs of right-sided heart failure. We will position the patient upright and leaning forward, and we will schedule activities to allow for frequent rest periods. We will administer oxygen therapy as prescribed. We will use incentive spirometry, right? And that is every hour, 10 times every hour during the hours that they are awake. We will also instruct the patient on breathing techniques, coughing, turning, deep breathing, and that should be done every 2 hours, as well as positioning the patient. We will encourage 2 to 3 liters of fluid per day unless it's contraindicated, and that fluid will help to thin out any of those tenacious secretions. We will also encourage a high-calorie diet and provide emotional support. The medications that can be expected to be prescribed, or we can see prescribed for your COPD patient, will include bronchodilators, beta-adrenergic agents, cholinergic antagonists, corticosteroids, methylxanthines, anti-inflammatory agents, and mucolytic agents. The therapeutic measures include chest physiotherapy, also known as chest PT, pulmonary drainage or positional drainage or postural drainage, lung reduction surgery, and let's go back to the postural drainage when we actually position the patient from side to side to help the drainage of fluid. Lung reduction surgery can also be performed for your patient. So when we talk about patient education and referral, breathing techniques, right? That pursed lip breathing, oxygen therapy, how to appropriately use their oxygen therapy, not to smoke while using oxygen therapy. Medications, we have to educate the patient on their medication regimen. Nutrition is going to be important, right? A lot of times, especially your emphysema patient, will have malnutrition. We also will promote smoking cessation. We will look at infection prevention measures. We will encourage immunizations for pneumonia and influenza. We will also look at pulmonary rehabilitation for our patients. And we will also want to teach our patients about activity pacing, prioritizing and completing the most important activities first, right? Doing those activities early in the day. Okay, complication of COPD, and this is something that is important to understand, which is right-sided heart failure caused by pulmonary disease. And this right-sided heart failure caused by pulmonary disease is known as cor pulmonale. Now, cor pulmonale has manifestations of hypoxia and hypoxemia, extreme dyspnea, cyanotic lips, JVD, or jugular venous distension, dependent edema, edema of the lower extremities, usually over the shins, right? Hepatomegaly is enlargement of the liver, pulmonary hypertension. So the nursing interventions for a patient with cor pulmonale: we will monitor their respiratory status. We will monitor their cardiac status and assess for indications of right-sided heart failure, right? And so all of those manifestations are going to be what we're looking for: hypoxemia, extreme dyspnea, the cyanotic lips, JVD, dependent edema, hepatomegaly, right? Pulmonary hypertension. So we will assess and monitor for those signs. We will also ensure that this patient has adequate rest periods. We will encourage a low sodium diet. We will maintain a fluid balance, possible fluid restriction for your cor pulmonale patient, and we will administer the medications as prescribed. The medications will probably consist of diuretics, so the patient can diurese. Remember, with diuretics, they should be taken first thing in the morning or early in the day, not at night, because the patient will have to get up throughout the night to go to the bathroom if we administer diuretics later in the day. Okay. Also, digoxin may be administered. The thing with digoxin, remember to always get the apical pulse for a full 60 seconds. When we talk about apical pulse, we have to remember the left mid-clavicular line, fifth intercostal space. Those are the landmarks that we need to remember for assessing the apical pulse, and we must listen or auscultate for a full 60 seconds. That's going to be very important. And if the patient's apical pulse is less than 60 beats per minute, we must hold the digoxin and notify the provider. Okay. Other therapeutic measures for a patient with cor pulmonale may be mechanical ventilation. The patient may require mechanical ventilation. All right, let's now jump to carbon dioxide toxicity. So this is the patient's going to be in a stupor, right? And this is secondary to increased carbon dioxide retention. So the picture here on the PowerPoint shows you how this carbon dioxide toxicity affects the entire system. So the contributing factors to carbon dioxide toxicity is patient having carbon dioxide retention, excessive oxygen delivery, right? So that's why our COPD patients, we don't want to give them large amounts of oxygen because that can potentially contribute to carbon dioxide toxicity. Manifestations of carbon dioxide toxicity: alteration in level of consciousness, tachypnea, increased blood pressure, tachycardia with dysrhythmias. So care for this patient with carbon dioxide toxicity will consist of monitoring the pulse oximetry, ABGs, avoiding excessive concentrations of oxygen, provide pulmonary hygiene, and provide ventilatory support with CPAP, BiPAP, or mechanical ventilation. Okay, so that is your carbon dioxide toxicity. Let's now go to pneumonia. So pneumonia is an inflammatory process in the lungs that produces excess fluid and exudate, and this fluid and exudate fills the alveoli. So there's different types of pneumonia. They can be classified as bacterial, viral, fungal, or chemical. So contributing factors to pneumonia: advanced age, right? No pneumococcal vaccination within the last 5 years. No influenza vaccine within the last year. The patient may also have contributing factors of chronic lung disease. They may be immunocompromised. The patient may be on mechanical ventilation. Maybe the patient is a post-operative patient. Maybe the patient was sedated or using opioids, or prolonged immobility could be a contributing factor, tobacco use, and enteral tube feeding. So what are the manifestations of pneumonia? Well, tachypnea and tachycardia, a sudden onset of chills, fever, flushing, diaphoresis, a productive cough, dyspnea with pleuritic pain, crackles, elevated white blood cells, decreased O2 saturations, right? And the diagnostic procedures for this patient with pneumonia, we would expect to see chest x-ray, pulse oximetry, sputum culture, and sensitivity. The nursing interventions for the patient with pneumonia is going to be assess their respiratory status, administer oxygen, assess the sputum, monitor their vital signs, and encourage 3 liters of fluid per day. Will provide pulmonary hygiene, will encourage mouth care, and promote nutrition. The medications we can expect to see prescribed are going to be anti-infectives, antipyretics, bronchodilators, anti-inflammatories, and the client education. We have to teach them about their medication administration, the preventative measures, right? How to prevent getting pneumonia. And then we will also educate the patient on the importance of the pneumonia and influenza vaccine. All right, let's get into tuberculosis. Tuberculosis is an infectious disease that is caused by Mycobacterium tuberculosis, and it is transmitted, through aerosolization. So it is airborne. So the contributing factors to a patient contracting tuberculosis, well, older and homeless populations, lower socioeconomic status, foreign immigrants, those in frequent contact with untreated persons, and overcrowded living conditions like you would see in detention centers or border facilities in prisons. So what are the manifestations of tuberculosis? Well, cough, hemoptysis, right? So bloody sputum, positive sputum culture for acid-fast bacillus, low-grade fever with night sweats, anorexia, weight loss. The patient may also manifest with malaise and fatigue. The diagnostic procedures that goes with tuberculosis will be your Mantoux test, your sputum culture, and smear, and we're looking for acid-fast bacillus to confirm the diagnosis. We will also do a serum analysis looking at the quantiferon for TB. We will also look for chest x-ray to be prescribed or done for this patient as a diagnostic procedure. So for tuberculosis, your nursing interventions include initiating airborne isolation precautions. So a negative pressurized room. If the patient has to come out of the room, they must wear a mask. We will wear an N95 mask, right? So obtain a sputum sample before administering medications. Maintain adequate nutritional status. Teach the client to avoid foods containing tyramine when taking Ionazet or INH. Inform the patient that rifampin can cause metabolism or can alter rather the metabolism of other medications. We will also monitor laboratory findings for liver and kidney function. The medication, so we could expect to see for TB can be rifampin, isoniazid, pyrazidamide, and ethambutol. Okay, so with these medications, they should be taken 6 to 12 months. The medications must be given on an empty stomach at the same time every day. So the patients should also be instructed to watch out for signs and indications of hepatotoxicity, nephrotoxicity, visual changes or visual disturbances, and they should notify the provider if they have any signs that indicate this. Okay, so we will educate the patient to follow the infection control measures, and we want to educate them on the importance of medication compliance and follow-up care. This is important also. This tuberculosis is a mandatory reported condition to the Virginia Department of Health. Any patient that is high risk, we must send them or refer them to the local health department for testing and prophylactic treatment. Okay, so one thing to remember about these medications, rifampin and isoniazid, and pyrazinamide and ethambutol, they must be taken on an empty stomach at the same time each day, and they should be taken for 6 to 12 months. So that's going to be really important to educate your patients on. Okay, let's now go to laryngeal cancer. Laryngeal cancer, malignant cells occurring in the mucosal tissue of the larynx, more common in men between the ages of 55 and 70. Contributing factors to laryngeal cancer: smoking, radiation exposure, chronic laryngitis, and or straining of the vocal cords. Manifestations of laryngeal cancer: hoarseness extending longer than 2 weeks, dysphagia, dyspnea, cough, persistent sore throat, hard immobile lymph nodes, so hard immobile lymph nodes in the neck, weight loss, and anorexia. Diagnostic procedures for laryngeal cancer consist of MRI, direct laryngoscopy with biopsy. So remember, whenever there's a scopy or a scope, they're taking a flexible tube with a camera to visualize the structures. Other diagnostic procedures for laryngeal cancer can include X-ray and CT scan, bone scan, and PET scan. And the PET scan is a positron emission tomography. So nursing interventions, we want to maintain a patent airway. The patient may be on swallowing precautions. We will provide emotional support, nutrition, pain management, and administer medications as an elixir when possible. Therapeutic measures may be a partial or total laryngectomy. Remember, if a patient has a complete or a total laryngectomy, their airway and their esophagus, right, are totally separated. So there's no longer a risk for aspiration. In case you see that for some kind of question, a patient with a total laryngectomy, their airway and their food pipe or their esophagus are totally separated, so there's no risk of aspiration. Other therapeutic measures can be radiation therapy, and a patient teaching and referral. We need to think about how are we going to communicate with the patient. That's going to be important. How are we going to communicate with the patient? Okay, stoma care is going to be important to teach. Swallowing maneuvers, as well as speech therapy, Our last condition to discuss is going to be lung cancer. Okay, so lung cancer is the leading cause of cancer-related deaths for both men and women in the United States. So it can be primary or metastatic, meaning that it spreads, and it most commonly occurs between the ages of 45 and 70 years old. Contributing factors to lung cancer: smoking, right? Cigarette smoking, as well as being exposed to secondhand smoke. Radiation exposure is another contributing factor. Chronic exposure to inhaled irritants. If the patient is an older adult, they're also at risk for lung cancer. What are the manifestations of lung cancer? Well, we'll see possibly a chronic cough, chronic dyspnea, hemoptysis, hoarseness, fatigue, weight loss, anorexia, clubbing of fingers, chest wall pain. The diagnostic procedures for lung cancer consists of chest X-ray and CT scan, CT-guided needle aspiration, bronchoscopy with biopsy, and we think about the TNM system for staging. T as in Tango stands for tumor. N as in November stands for nodes, the lymph nodes, and then M as in Mike stands for metastasis. So the T and M is how we stage these cancerous growths, right? The lung cancer. And the higher the number is, the more serious the cancer is. So the T stands for the size of the tumor, the N stands for the nodes, has this cancer spread to the local lymph nodes? And M is is for metastasis. Has the cancer spread from the primary location, from maybe from the lungs to the kidney or to the brain, right? So let's talk about our nursing interventions for a patient with lung cancer. Well, you probably guessed it, maintaining that patent airway. Suction as indicated by assessment, monitoring vital signs and pulse oximetry, monitor nutritional status, position the patient in high Fowlers. We will provide emotional support, and we will assess and treat for stomatitis. And we will also ensure protection for the immunocompromised patient. Medications we could expect to see will be your chemotherapeutic agents, as well as opioid narcotics. Therapeutic measures taken for your patient that has lung cancer. Well, palliative care, medication, managing that pain, thoracentesis can be performed to remove excess fluid. Surgery can be done to actually remove the tumor. It's called tumor excision. The patient may also have a pneumonectomy, lobectomy, or wedge resection, where they're actually removing one of the lungs, a lobe of the lung, or just a section of the lung. And yes, we can live with one lung. And remember that the right lung has 3 lobes and the left lung has 2 lobes. Other treatments that we can have, or surgical interventions, or just interventions in general for your patient with lung cancer, can also be radiation. Remember those radiation markings, we should not wash them off. And it's kind of neat that you have your clinical rotation on an oncology unit, so you may actually see those markings. They're usually like a sky blue marking with lines, 4 lines, and the laser will be pointed into the middle of where those lines are kind of showing that, and that's important. We never remove or wash off those markings. Okay, so when we educate our patients with lung cancer, we want to make sure they understand their medication regimen, how to prevent constipation. We want to stress the importance of mouth care and skin care, nutrition. We also want to provide them with information about respiratory services, radiology, rehabilitation, nutrition, and hospice. Okay, let's take a look at an NCLEX question, and let's kind of break it down. A male patient is admitted to the healthcare facility for treatment of chronic obstructive pulmonary disease. Which nursing diagnosis is most important for this patient? So when I see most important, that tells me this is priority, and it tells me that these answers are probably all going to pertain to the COPD patient. But what I have to remember is the one that is the most important. If I could choose one and I had to, discard the others, what would it be? Well, would it be activity intolerance related to fatigue, anxiety related to actual threat to health status, risk for infection related to retained secretions, or impaired gas exchange related to airflow obstruction? Well, you probably guessed correctly, and the correct answer is D, impaired gas exchange related to airflow obstruction. So this patient, we really want to, make sure that they have a patent airway. And when we think about this, it should be reminding you of your ABCs, your airway, breathing, and circulation. That's going to be one of the most important things that we should focus on for our patient. Okay. Before I end, I just want to mention some respiratory emergencies. So one is going to be pulmonary embolism. So the pulmonary embolism is a life-threatening emergency, right? And so this is a hypoxic condition caused by a collection of particulate matter. It could be solid, it could be gas or liquid. So it's going to enter the venous circulation and lodges in the pulmonary vessels, and this causes pulmonary blood flow obstruction. Okay, so pulmonary embolism is a respiratory emergency. So you will note that the manifestations of pulmonary embolisms can be dyspnea, tachypnea, sharp stabbing pain on inspiration, tachycardia, hypotension, a sense of impending doom, diaphoresis, increased saturations of our oxygen saturations, pleural effusion, crackles, and cough. Please note when we're talking about pulmonary embolism, the petechiae over the chest and axilla are present with fat emboli, okay? So please note that petechiae over the chest and axilla are present with fat emboli. So you can see the differences between the pulmonary emboli and fat emboli. Just remember that fat emboli is a complication of a fracture of the long bone. Okay. The next respiratory emergency is pneumothorax. Pneumothorax is a collection of air or gas in the chest or pleural space that causes part of the lung to collapse or all of the lung to collapse due to a loss of negative pressure. Now, a tension pneumothorax occurs when air enters the pleural space during inspiration through one-way valve, right? And it's not able to exit upon expiration. This trapped air causes pressure on the heart and the lungs. As a result of the tension pneumothorax, the increased pressure compresses blood vessels, and limits venous return. And this is the leading cause to decrease in cardiac output, and death can result if not treated immediately. If you see a patient or you see a question where the patient's trachea is deviated to the side, it's not midline, that is a great indicator that this patient probably has a tension pneumothorax. Now, we've talked about the pneumothorax and tension pneumothorax. I just want to mention the hemothorax. A hemothorax is going to be an accumulation of blood in the pleural cavity, okay? An accumulation of blood in the pleural cavity. For these medical emergencies, respiratory emergencies, pulmonary embolism, pneumothorax, tension pneumothorax, hemothorax. Of course, respiratory status is going to be the most important thing, right? Assessing that respiratory status, administering oxygen, positioning the patient is going to be important. The high Fowler's position. We will monitor if the patient has a chest tube, provide emotional support, make sure the patient has an IV access, and understanding that these patients with these respiratory emergencies, it's possible for them to have a chest tube inserted, and that is specifically for your pneumothorax, tension pneumothorax, and hemothorax. With your pulmonary embolism, we're looking at thrombolytics and anticoagulants, okay? It's going to be the primary ways that we treat these respiratory emergencies. So this concludes our huddle on the respiratory system and respiratory system alterations. I know it's a lot of information, but hopefully it helps you as you study. Thank you, and remember to think like a nurse.